Most people dismiss what happens after they eat as just digestion, as the ordinary business of the body processing a meal, as something that does not warrant attention unless it becomes genuinely unbearable. And so the bloating gets attributed to the beans, and the fullness gets attributed to eating too fast, and the dull pressure below the ribs gets blamed on the coffee, and the pattern continues for months or years. And the assumption is that it is simply how digestion works for a person of a certain age and a certain diet and a certain level of gut sensitivity. I want to talk to you today about when that assumption is wrong and about the specific features of post-meal symptoms that distinguish the kind of digestive discomfort that genuinely reflects ordinary digestion from the kind that reflects something happening in the gut that deserves medical attention. Because the early warning signs of some of the most serious digestive conditions, including stomach cancer and colorectal cancer, do not arrive as dramatic pain or acute illness. They arrive as changes in the pattern of everyday digestion, changes that are easy to explain away, that are easy to attribute to diet or stress or aging, and that in many cases are being explained away for months or years, while a condition that was entirely treatable in its early stages becomes one that is far more difficult to manage. This is not a video designed to frighten you about normal bloating after a heavy meal, and I want to say that clearly at the start. Occasional post-meal discomfort is genuinely common, genuinely benign in most cases, and does not warrant investigation unless it meets specific criteria I am going to describe in detail. What I want to give you today is the framework to distinguish the occasional from the persistent, the benign from the concerning, and the pattern that warrants a doctor's attention from the one that warrants an antacid. Before anything else, what I share in this video is educational information only. It is not medical advice. If you are experiencing persistent digestive symptoms, particularly symptoms accompanied by any of the warning signs I am going to describe, please speak with your healthcare provider promptly. Early evaluation changes outcomes in gastrointestinal disease more dramatically than in almost any other area of medicine, and the window in which early-stage conditions are most treatable is defined by how quickly the right conversation happens. What I want to do today is help you recognize when that conversation needs to happen. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. The specific reason this topic matters so much to me is that gastrointestinal cancers, including stomach cancer and colorectal cancer, carry enormously better outcomes when they are caught at an early stage. An early-stage disease is almost universally asymptomatic, or produces only mild, non-specific symptoms that are indistinguishable at first glance from ordinary digestive complaints. The person who presents to me after a year of attributing their post-meal fullness to getting older is in a very different clinical position from the person who presented at the 3-month mark when the pattern first became consistent. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body is communicating after 60, and this video may prompt a conversation that genuinely matters. Let me start with the distinction between acute digestive discomfort and the kind of persistent change in digestive pattern that warrants medical evaluation, because this distinction is the single most important piece of information in this video. Occasional bloating after a large meal, temporary fullness after overeating, transient discomfort after a food that has always disagreed with you, brief nausea from eating something that was off. These are common. They reflect normal variation in digestive function, and, in the absence of any accompanying features, they do not require investigation. They are the background noise of digestion in a human body. What changes the picture is persistence and pattern. When a digestive symptom occurs frequently, meaning several times a week across a period of weeks to months, when it does not have a clear and consistent dietary explanation, when it represents a change from a person's previous baseline, when it is progressive rather than stable, or when it's accompanied by any of the additional features I'm going to describe, the symptom has moved from background noise into a signal that the gut is trying to communicate. A study published in the British Medical Journal found that persistent dyspepsia, the medical term for ongoing post-meal upper abdominal discomfort or fullness, was associated with an increased risk of gastric cancer in adults over 55, and that the risk was highest in those who had not previously experienced chronic reflux or known gastric disease, meaning the symptom represented a genuine change in their pattern rather than a familiar chronic condition. The persistence and the novelty of the symptom were the clinically significant features. This principle, that a new or changing pattern is more important than an absolute symptom severity, is central to how gastrointestinal symptoms should be evaluated. Severe bloating that has been happening after legumes for 20 years is very different from mild bloating that began appearing after every meal for the past 3 months. The severity is reversed, but the clinical significance is not even close. Type in the comments right now how long you have been experiencing whatever post-meal symptom brought you to this video. 1 week? 3 months? A year? The duration is the single most important piece of information in the clinical evaluation of any digestive complaint, and I want to see the range. The first specific symptom pattern I want to describe is early satiety, an unexplained fullness that comes on during a meal that is not large, a sensation of being full, or of the stomach being full much sooner than would be expected given the amount eaten. In ordinary digestion, the stomach accommodates a meal through a process called gastric accommodation, in which the fundus, the upper portion of the stomach, relaxes and expands to receive food. As the stomach fills, stretch receptors signal satiety. This is a gradual process that normally allows a full meal to be consumed before the fullness signal becomes overwhelming. When early satiety occurs, one of several things may be happening. The stomach may not be accommodating normally, a condition called impaired accommodation, which can result from inflammation of the stomach lining, from vagal nerve dysfunction, or from a mechanical process that is reducing the stomach's ability to expand. The stomach may be emptying more slowly than normal, a condition called gastroparesis, which creates a sense of fullness that persists from a previous meal into the next one. Or there may be an abnormality in the stomach wall itself, a lesion or a thickening, that is physically reducing the stomach's capacity. In adults over 60, a new and persistent symptom of early satiety, particularly one that has developed over a period of weeks to months without a clear dietary explanation and without a change in the type or quantity of food being eaten, warrants upper gastrointestinal evaluation. In upper endoscopy, in which a camera is passed through the mouth into the stomach and the first part of the small intestine, can directly visualize the stomach lining and identify any concerning changes, including thickening, ulceration, or growth, that would be completely invisible on any other test. We want to be specific here. Early satiety that has been present for years and has remained stable is far less concerning than early satiety that has developed or worsened over the past 3 to 6 months. The change in trajectory is the signal. The second symptom is one that is easy to conflate with common acid reflux, but that has a specific presentation worth distinguishing. Persistent upper abdominal discomfort or pressure after eating, in the upper middle or upper left area of the abdomen, that does not reliably respond to antacids, that is not clearly associated with specific foods or dietary patterns, and that has become more frequent or more intense over time, rather than remaining stable. Ordinary acid reflux produces a burning sensation that is typically felt in the lower chest or upper abdomen, and that responds to antacids because it is caused by acid contact with tissue. The burning of reflux is usually worse when lying down, worse after large or fatty meals, and relieved at least partially by antacid use. The discomfort associated with early gastric disease often has a different quality. It is frequently described as pressure, aching, or heaviness rather than burning. It may be present even after small meals. It may not correlate reliably with antacid use, and it may have a more consistent relationship to the act of eating in general, rather than to the specific content of what was eaten. This non-specific quality, the sense that eating itself has become uncomfortable rather than that specific foods cause problems, is a clinically important distinction. A study published in the journal Gastroenterology found that new-onset upper abdominal discomfort in adults over 55 without a prior history of functional dyspepsia had a meaningful association with upper gastrointestinal pathology requiring endoscopic investigation, and that waiting more than 6 weeks before evaluation significantly reduced the likelihood of early-stage identification in cases where malignancy was present. 6 weeks, not 6 months. For a new and persistent upper abdominal symptom in an adult over 55, without a prior history of the same symptom, 6 weeks is the clinical threshold that evidence supports for upper endoscopy referral. Most adults wait far longer before reporting the symptom to their doctor at all. And share this video right now with one person in your life over 60 who has been self-managing upper abdominal discomfort with over-the-counter antacids for more than a month without reporting it to their doctor, because the video they need to see is this one. And if you are not yet subscribed to this channel, tap that button now and ring the bell, because every week I come here with exactly this level of specific, clinically grounded information. I want to tell you about Robert, 67 years old, retired engineer from Seattle, Washington. He had been experiencing a vague sense of fullness after meals, not pain exactly, but a persistent pressure in the upper abdomen that arrived early in a meal and stayed for 1 to 2 hours afterward, for approximately 4 months before he mentioned it, at an appointment that had been scheduled for an entirely different reason. He had been managing it with antacids that he described as helping somewhat, but never fully resolving the symptom. He had attributed it to the same acid reflux he had experienced intermittently for years, but when I asked him to compare the current symptom to his previous reflux, he was quiet for a moment, and then said, "Actually, it is different. It is not really burning. It is more like a weight." That distinction mattered. His previous reflux had been burning, had been clearly worse after fatty food and coffee, and had been reliably managed by antacids. This symptom was pressure, had no clear food correlation, and was only partially managed by antacids he had been taking for 4 months. I referred him for upper endoscopy. A lesion was found in the gastric body. Biopsy confirmed early-stage gastric adenocarcinoma. Early stage. Entirely within the stomach wall, no lymph node involvement, no distant spread. He had surgery within weeks. His surgeon told him that the prognosis at this stage was dramatically better than at a later presentation, and that the most important factor in finding it early was his doctor recognizing that the symptom had changed from his baseline pattern. Robert told me I almost did not mention it. I told him, the difference between mentioning it at 4 months and mentioning it at 14 months is, in some cases, the difference between an operation and a conversation about what options remain. There is one more layer to the gastric cancer risk picture that I want to add, before we move to the lower digestive tract, because it is directly relevant to adults over 60 and is almost never discussed in the context of post-meal symptoms. Helicobacter pylori, the bacteria that colonizes the stomach lining and is the primary cause of gastric ulcers, is also the strongest known environmental risk factor for gastric cancer. H. pylori infection is present in approximately 40% of adults worldwide, is more common in adults who grew up in conditions of lower sanitation, and in many people produces no symptoms for decades while quietly driving chronic inflammation in the stomach lining that, over years and decades, increases the risk of precancerous change and malignant transformation. Many adults over 60 with H. pylori infection do not know they have it. They have had mild gastric symptoms for years that were treated with antacids without anyone testing for the underlying infection. And a simple, non-invasive breath test or a stool antigen test can confirm or rule out active H. pylori infection. If you have had persistent upper digestive symptoms and have never been tested for H. pylori, ask your doctor about this test specifically. Eradicating H. pylori with a standard antibiotic course reduces gastric cancer risk significantly, and that reduction is available to anyone who is tested and treated before the infection has had time to produce irreversible mucosal changes. The third symptom pattern I want to address is lower in the abdomen and more directly associated with changes in bowel habit, and it reflects a completely different part of the digestive tract, but follows the same principle of pattern change being the critical signal. Persistent change in bowel habit, meaning a new and consistent change in the frequency, consistency, or character of bowel movements that has been present for more than 4 weeks without a clear dietary explanation, is one of the primary symptoms of colorectal cancer and one of the most consistently delayed in reaching medical evaluation. The specific changes that warrant investigation are a persistent shift toward looser stools or more frequent bowel movements that is new and unexplained, a persistent shift toward harder stools, or constipation in someone who has not previously experienced this, a new and consistent sense of incomplete evacuation after a bowel movement, or the appearance of narrow or ribbon-like stools that suggest narrowing of the bowel lumen. Any of these changes, present consistently for more than 4 weeks in an adult over 50, warrants colonoscopy. The conversation about bowel habits is one that most people find uncomfortable to have with their doctor, and that discomfort is one of the primary reasons colorectal cancer continues to present at later stages than it should. The cancer itself does not respect the social awkwardness of the conversation. What happens in the bowel is clinical information. It deserves a clinical conversation. You want to be direct about colorectal cancer screening specifically, because the numbers make the case clearly. Colorectal cancer caught at the local stage, meaning confined to the colon wall without lymph node spread, has a 5-year survival rate above 90%. Colorectal cancer caught at the distant stage, meaning after it has spread to other organs, has a 5-year survival rate of approximately 14%. The cancer itself does not change between these two presentations. The difference is entirely in when it was found. And the primary tool for finding it early is colonoscopy, combined with the willingness to report symptomatic changes before they become undeniable. The fourth pattern involves symptoms that exist alongside the digestive complaints and that, when present together, significantly elevate the urgency of evaluation. Unintentional weight loss alongside any persistent digestive symptom is the combination that most urgently requires investigation. Losing more than 5% of body weight without making dietary changes or increasing exercise activity in the context of any ongoing digestive symptom is a red flag that demands prompt evaluation, not a wait-and-see approach, not a check-in at the next scheduled appointment. A prompt, specific conversation with a doctor describing the weight change and the digestive symptom together, fatigue that is disproportionate to the person's activity level, the kind of fatigue that is present even after adequate sleep, that represents a change from baseline, and that is accompanied by any persistent digestive symptom, warrants the same prompt response. This combination can reflect iron deficiency anemia from occult gastrointestinal bleeding, a situation in which a cancerous or precancerous lesion in the gastrointestinal tract is bleeding slowly and invisibly into the bowel, depleting iron stores over time without any visible blood. Blood in the stool or stool that is black or tarry, dark and foul-smelling in a way that differs from normal stool, should prompt same-day or next-day evaluation rather than watchful waiting. Bright red blood from the rectum may reflect hemorrhoids, which are common and benign, but it may reflect lower rectal cancer, and the two cannot be distinguished by appearance alone. Any rectal bleeding in an adult over 60, without a prior confirmed diagnosis of hemorrhoids as the source warrants evaluation, and black tarry stool, which indicates blood from higher in the digestive tract that has been partially digested during its passage, warrants same-day evaluation. A study published in JAMA Oncology found that a combination of even two of these features, persistent post-meal discomfort alongside unexplained weight loss, was associated with a risk of gastrointestinal malignancy high enough to justify immediate investigative referral in primary care. The features individually are not diagnostic. Together, they form a pattern that clinical guidelines identify as urgent. Type yes in the comments right now if you or someone you know has been experiencing more than one of the features I just described and has not yet had them specifically evaluated together. Because the combination is the signal, not the individual symptom. And subscribe to this channel if you have not yet, because every week I come here with exactly this kind of information that the standard appointment does not always have time to deliver. Let me now talk about the connection between chronic digestive symptoms and the metabolic conditions that can either produce or amplify them, because this dimension of the picture is almost never discussed in the context of gastrointestinal health, but is directly relevant to the adults most likely to be watching this video. Insulin resistance and chronic elevated blood glucose affect the gut in ways that are specific and measurable. The autonomic nerves that regulate gut motility, the movement of food through the digestive tract from the stomach into the small intestine and then into the colon, are among the first peripheral neural structures to be damaged by the cumulative oxidative stress of chronically elevated glucose. This condition, called autonomic neuropathy of the gut, produces delayed gastric emptying and slowed colonic transit that manifest as bloating, premature fullness, and a sense of heaviness after meals that is metabolic in origin rather than structural. In adults with poorly controlled or long-standing prediabetes or type 2 diabetes, these motility disturbances are common and frequently attributed simply to aging or to dietary choices, rather than to the underlying metabolic condition driving them. Addressing blood glucose control in these patients sometimes produces meaningful improvement in post-meal symptoms that years of dietary modification had not achieved, because the underlying nerve dysfunction was not addressed by dietary changes alone. The gut microbiome, the community of bacteria living in the large intestine, is also profoundly affected by blood glucose dysregulation, by chronic antibiotic use, by the ultra-processed dietary pattern that reduces dietary fiber, and by a wide range of medications common in older adults, including proton pump inhibitors and metformin. A disrupted microbiome alters the fermentation of dietary fiber in the colon, producing excess gas and altered stool consistency. It shifts the inflammatory tone of the gut wall toward a more pro-inflammatory state. And emerging research suggests that certain microbial dysbiosis patterns are associated with higher rates of colorectal adenoma formation, the precancerous polyps that precede colorectal cancer. This does not mean that bloating caused by gut dysbiosis is directly a cancer risk. It means that the same metabolic and dietary conditions that produce the chronic post-meal digestive symptoms I have described are also the conditions that drive the inflammatory gut environment in which precancerous changes are more likely to develop. The symptoms and the risk share the same upstream drivers. And addressing those upstream drivers through dietary pattern improvement, blood sugar management, and appropriate screening simultaneously reduces the symptom burden and the long-term risk. Here is the framework I want you to use to evaluate your own post-meal symptoms and to determine when medical evaluation is warranted and how urgently. Symptoms that require same-day or next-day evaluation: any rectal bleeding, any black or tarry stool, any severe abdominal pain that is new or significantly worse than baseline, any sudden complete inability to have a bowel movement accompanied by abdominal distension, and any post-meal symptom alongside unintentional weight loss of 5% or more. Symptoms that require a doctor's appointment within 2 to 4 weeks. Any new and persistent post-meal upper abdominal fullness, pressure, or discomfort that has been occurring several times per week for more than 4 weeks and does not have a clear dietary explanation. Any new and persistent change in bowel habit, including frequency, consistency, or character, that has been present for more than 4 weeks. Any combination of ongoing digestive symptoms with disproportionate fatigue or unexplained pallor. And any digestive symptom that represents a clear change from a prior baseline in an adult over 60, particularly if the symptom is progressive rather than stable. Symptoms that are less urgent but warrant monitoring and dietary evaluation. Occasional bloating after large or gas-producing meals. Transient discomfort that reliably follows specific foods. Post-meal fullness that is present only after genuinely large meals. These symptoms are common, are frequently managed with dietary adjustment, and do not require immediate investigation in the absence of the concerning features I described above. The practical actions I want you to take if you have been experiencing digestive symptoms that concern you are the following. First, describe your symptoms to your doctor specifically, and in terms of duration, frequency, and whether they represent a change from your previous baseline. These 3 pieces of information are the most important clinical context your doctor needs. Second, ask specifically whether an upper endoscopy or colonoscopy is appropriate given your symptom pattern, your age, and whether you are current on colorectal cancer screening. Third, ask about a fecal occult blood test if you have not had one recently, which detects invisible blood in the stool, and is a simple, non-invasive first-line screen for colorectal disease. Fourth, ask your doctor to check your iron levels, your hemoglobin, and your inflammatory markers if you are experiencing fatigue, alongside digestive symptoms, because these together reveal whether there is an anemia or inflammatory process driving your symptoms from below the surface. 4 things to carry away from this video. First, the clinical distinction that matters most in evaluating post-meal digestive symptoms is not severity, but persistence and pattern change. A mild symptom that has appeared consistently for 3 months and represents a change from a person's previous baseline is more concerning than a severe symptom that has been reliably present after the same foods for 20 years. Novel, progressive, and consistent are the 3 features that warrant investigation. Second, upper gastrointestinal cancer, including stomach cancer, typically presents in its early stages with mild, nonspecific symptoms, including early satiety, post-meal pressure, and upper abdominal discomfort, that are easy to attribute to acid reflux or dietary causes. The 6-week threshold for upper endoscopy referral in adults over 55, with new-onset upper GI symptoms, exists precisely because the window for early-stage identification is time-limited. Third, bowel habit change, the uncomfortable conversation most people delay, is the primary symptom of colorectal cancer, and the primary reason its early-stage detection rate remains lower than it should be. Colorectal cancer caught early is one of the most survivable cancers in medicine. Caught late, the picture is entirely different. The bowel habit conversation with your doctor is the conversation that changes that equation. Fourth, The metabolic conditions driving many chronic post-meal digestive symptoms, insulin resistance, gut dysbiosis, and autonomic neuropathy from glucose exposure, are the same conditions that create the inflammatory gut environment in which precancerous changes are more likely to develop. Addressing blood sugar, dietary fiber, and medication burden in the context of chronic digestive symptoms addresses both the immediate symptom and the long-term environment simultaneously. Your digestive system has been processing everything you have eaten across your entire life, adapting to seasonal changes in diet, to stress, to illness, to medications, and to the gradual shifts of aging. When it changes its pattern in a way that is persistent, unexplained, and new, it is not simply struggling with aging. It is communicating. And the communication that your gut is offering in the form of a changed post-meal pattern is among the most important information your body produces, because the conditions it can reflect, when caught early, are conditions where early means everything. Share this video with one person in your life over 60 who has been self-managing persistent digestive symptoms without reporting them to their doctor, because the decision not to report is the decision that costs the most. And subscribe to this channel, because every week I come here with one purpose: to give you the specific information that ensures your symptoms get the attention they deserve. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself. If you feel this after eating, it could be cancer.